I'll hand over the mic to the chairperson of today's session, Professor Tariq Khan Marwat, to start with, and then I will moderate the session.
Thank you, sir. Well, this session is more related to diabetic retinopathy and diabetic maculopathy. Nasir Chaudhry was expected to come, but I think he's not around. So we are getting late, and I think we should start the session. Over to you, sir.
Now, Bismillahirrahmanirrahim. We are going to start with Medical Retina Symposium 2, Diabetic Macular Edema Updates. Now, I'll request Professor Tariq Khan Marwat for his talk on evolving treatment of diabetic retinopathy. Professor Tariq Khan Marwat.
So I'll be talking about the evolving treatment of diabetic retinopathy. I declare no financial interest for this presentation. We all know that diabetes is becoming a major health challenge, and worldwide the prevalence is getting close to 9%. That is 463 million people were affected from diabetes in 2019. But there are other issues like more than 6% of the world's population is at high risk of developing diabetes, and another 50% diabetics, they are still undiagnosed. They don't know about their health issue, and overall 10% of the health expenditure worldwide is spent alone on diabetes, and that becomes $1 trillion per year. More than 35% of the premature deaths, like those deaths under 60 years of age, which are directly or indirectly caused by diabetes. And 3 in every 4 diabetics are amongst the working age population. Also, 3 in every 4 diabetics are from low income economies. So these are some challenges that the world is facing now related to diabetes and its complications. A very unfortunate thing is that Pakistan has the highest diabetes prevalence in the world. That is 30.8% according to the recent data. Worldwide, if we see, out of the 463 million diabetics, 21% are having some level of diabetic retinopathy. 4% are having proliferative diabetic retinopathy, or more than that, that is advanced diabetic eye disease. And 7% of the world's diabetic population, they are having some level of diabetic macular edema. Till date, we have different treatment modalities available, like lasers, pharmacotherapy, and vitreoretinal surgeries. Right from the 1949, when Mayer Schwickerath used sunlight to treat retinal diseases, we have been using different lasers for treating diabetic retinopathy, like xenon, ruby laser, argon, green, and nowadays we are using yellow laser. There are some benchmark studies like diabetic retinopathy study, ETDRS, and DRCR net protocols, which are advocating laser treatment for diabetic retinopathy. Many of the DRCR net protocols have proved laser to be effective in the different stages of diabetic retinopathy. I'm not going into the details of that. We are all well aware of the different patterns of lasers while treating diabetic retinopathy, like PRP, the focal laser, and the grid laser. Nowadays we are using yellow laser frequency. This is a safe and versatile wavelength. Better penetration through the cataract is possible. Negligible macular absorption is there, and it performs PRP at a lower energy level. Another option is the subthreshold micropulse laser, which ensures better preservation of the retinal tissues and avoids visible scarring. pattern scan laser, that is the Pascal laser, is nowadays in fashion, and it is available with yellow wavelength. PRP takes less time with it, and it is less painful and less fatiguing to the physician. Another option is Nivalis, and this is basically a navigated laser system. It is automated. It is precise, accurate, and less painful. It automatically decides the laser pattern according to the pathology, and it automatically applies the laser. So PRP has been the standard care for PDR for a very long time, but there are some issues like it is painful and destructive. It causes peripheral and night vision loss. The macular edema can be titrated with it. It can cause mydriasis and loss of accommodation. It can cause CNVs and retinal detachments, and 20% of eyes still experience severe visual loss despite PRPs. So then comes the pharmacotherapy. Before discussing that, I would like to go through the risk factors of diabetic retinopathy: hyperglycemia, hypertension, hyperlipidemia, nephropathy, atherosclerosis, obesity, sedentary lifestyle, pregnancy, smoking, anemia. These are all known risk factors in developing diabetic retinopathy or in the rapid progression of diabetic retinopathy. So, all the pharmacotherapy is mainly targeted against these cofactors or risk factors, and it may include systemic pharmacotherapy, intravitreal drugs, suprachoroidal drugs nowadays are in fashion, and then topical are under research. Amongst the systemic pharmacotherapy, we all know about that the intensive insulin therapy delays the progression of diabetic retinopathy. So nowadays, the internists or the endocrinologists, they are focusing more to shift the patient from orals to insulin while treating those patients who are also having concurrent diabetic retinopathy. Lipid lowering drugs like phenofibrates and atorvastatin, these are uh, known to be effective in delaying the progression of diabetic retinopathy. Same is the antihypertensive agents like AC inhibitors and antiplatelet agents like aspirin and dipyridamole. Some other systemic drugs have been proved to be effective in delaying the progression of diabetic retinopathy, like antioxidants, like ruboxostarvin, like somatostatin derivatives. They have been studied and they have been proved to delay the progression of diabetic retinopathy. And then comes the anti-VEGFs. We are all aware of these anti-VEGFs. We have been using these for more than 15 years now. And these are different studies which have proved the efficacy of these anti-VEGFs in progression of diabetic retinopathy. And these are different ongoing studies. Some are ongoing studies, some have been conducted, but there are some limitations of using anti-VEGFs. One is the high cost. If you compare the use of anti-VEGFs in comparison to the PRP, the cost is high. There are more visits are needed, or operation theater interventions are needed. Treatment period is usually not determined. Despite treatment with anti-VEGFs, 30% of eyes continue to worsen. And transient IOP rise, endophthalmitis, and TRDs, they are additional possible side effects or complications. Next is the steroids. Although unfortunately these implants are not available, and we have been using intravitreal triamcinolone acetonide for many years for resistant cases of diabetic macular edema and diabetic retinopathy. But worldwide, these are FDA approved and available and effective treatment modalities. Suprachoroidal is a novel route of drug delivery. Therapeutic effects are similar or superior to intravitreal routes. Nowadays, suprachoroidal triamcinolone that has been proved to be effective in some of the resistant cases, selected cases, and we have been using this modality or this route for now almost 5 years. The topical anti-VEGF's role is under trial. It is going on through the phase 3 stage. Surgery indications include non-clearing or dense vitreous hemorrhage, pre-retinal bleed over the macula, TRD involving macula, combined tractional rhegmatogenous retinal detachment, VMT, ERM, TART posterior highlight, membrane or fibrous tissue in the visual axis, and very resistant to the treatment, the diabetic macular edema. The major studies that have proved the surgery to be effective includes DRVS and Protocol D. Uh, Here it is important to mention the role of preoperative anti-VEGFs. Preoperative bleed from fibrovascular proliferation is a major challenge while doing PPV for diabetic TRDs, and pre-treatment actually reduces this peroperative bleed and decreases the occurrence of post-operative cavity bleed. Future trends amongst the diagnostic modalities, uh, there is a shift towards artificial intelligence based maneuvers, and nowadays the diabetic retinopathy screening worldwide is mostly performed through the AI based softwares. The FDA has already approved few of these softwares, and few of the gadgets, like DeepMind is one of the renowned software. Next comes the multi-modeling imaging technology. Many of the companies, they are now coming up with machines which are having many options, including wide field or ultra wide field fundus imaging, OCT, OCT NGO, FAF, FFA, ICG, and ERG. One example is the Mirante, which is marketed by NIDEC, is having few of these options. Future trends in the treatment include gene therapy, which is targeted to help eye make its own anti-VEGF. There is a lot of discussion going on throughout the world regarding this new treatment modality, and a harmless virus is actually inserted into a patient's DNA, and that actually manufactures anti-VEGF by itself. And this is going to be the new treatment modality in the coming couple of years. Stem cell transplantation is under research for a long time, but ethical and immunological concerns are the big challenges. Retinal implants, including Argus 2, and so many other implants, they are under research. Argus 2 research has been abandoned recently, but huge research is underway in the optoelectric and nanotechnology already. The new modality that is coming for those hopeless cases uh, includes the Elon Musk Neuralink blind sight implant, which has recently got the FDA's breakthrough device tag, and probably it is going to be approved by the FDA in the next year. So, in conclusion, to date, diabetic retinopathy is still best treated by lasers or a hybrid of lasers and injections. Individualize your patients and eyes and decide the best plan. Follow up is crucial. Risk factors controls plays a pivotal role. Thank you very much.
Thank you, Professor Tariq Khan Mulwat. Now I'll request Dr. Shehzad Shafkat for his presentation on real-world data on faricimab in treatment naive DMO at Russell's Hospital, Dudley.
Yes. Thank you very much, Shahid. We just listened to a lovely presentation by Tariq Saab. So we'll swiftly move on to one of the things he was talking about, and that's anti-VEGF injections. Before I start, let me just say that anti-VEGF injections are the mainstay and the first line of treatment in the UK for center involving clinically significant diabetic macular edema. Laser still has a role, but we use laser as a deferred option. So the patient has a loading dose of 3 to 5 injections of Eylea is our preferred drug, or has been, and we have now moved on to faricimab, like in my department. And if the patient needs macular laser, then after the loading dose, that's when we give macular laser. But the mainstay of treatment is anti-VEGF injections. We also use steroids for diabetic macular edema, like Ozurdex, and the longer-lasting Iluvien. In certain cases, first line, when patients have needle phobia or they have learning disabilities, and we can't bring them every month for an injection, it's because they need either sedation or GA, then we use steroids. Also, patients who have had a stroke, mini stroke, heart attack, or heart failure, especially an episode in the last 3 months, then the preferred treatment, if it's that urgent that we need to start immediately, then we start off with steroids. And lastly, if young female patients who are either pregnant or lactating, in those cases as well, anti-VEGFs are contraindicated. So, moving on to faricimab. These are my disclosures. The only relevant one here is Roche. So I'm going to talk about the real-world data on faricimab in diabetic macular edema in the UK. Faricimab is the first-in-class bispecific antibody for intraocular use. It binds Ang2 and VEGF-A with high specificity and potency. Faricimab was licensed for use in May 2022, and we were able to use it. We were the very first users of faricimab in the country. The faricimab molecule contains 2 long chains and 2 short chains. It has a anti-VEGF-A antibody fragment, which neutralizes VEGF-A, which is the most important VEGF. There are 3 VEGFs, A, B, and C, out of which A is the most important one in neovascularization and retinal vascular diseases. And it has an angiopoietin-2 inhibitor antibody fragment, which neutralizes Ang2, and we'll see how important Ang2 inhibition is in retinal vascular disease. And it has a crystallizable fragment, which is there to reduce the antigenicity of the drug. So the drug itself does not give rise to an immune reaction and is not identified by immune surveillance in the body as a foreign protein. So FarWide is a electronic medical record system, a collection of 21 NHS sites in the UK, collecting data on diabetic macular edema in these patients, and all patients who had at least 1 injection of faricimab for DMO after June 22 were included in the study. So this is how faricimab works under physiological conditions. The angiopoietin pathway maintains vascular stability and homeostasis. It does so by Ang1, which is released by platelets and endothelial cells, which attaches itself to the tyrosine kinase epidermal growth factor 2 ligand. By attaching itself to Ty2 receptors, angiopoietin 1 then gives rise to a cascade pathway, which ends up in the result of tightening of endothelial cell junctions. It recruits pericytes and increases the lifespan of the pericytes, which wrap tightly around the delicate retinal capillaries, and that results in maintenance of vascular stability and homeostasis. This is normally what happens. However, we know that in retinal vascular disease, diabetic retinopathy, retinal vein occlusion, there is upregulation of inflammatory cytokines in the vitreous, including VEGF-A and angiopoietin-2. So angiopoietin-2 then inhibits Ty2 receptors, and that does not lead to activation of that cascade of events. So it blocks Ty2 receptors. Furthermore, angiopoietin-1 levels are low, and VEGF-A then attaches itself to the VEGF receptor 2 on the endothelial cells. So the combined effect of VEGF receptor 2 activation by VEGF and inhibition of TIE2 receptors by angiopoietin 2 leads to endothelial tight junctions weakening, vascular leakage, increased inflammation, leukocyte migration. The pericytes, they become loose, and there is apoptosis of pericytes, that they don't last as long as they normally do. And the end result is vascular sprouting. Also, immature leaky vessels contribute to fibronectin deposition. The fibronectin is a toxic substance in the intercellular matrix, which causes fibrosis. And that's why in patients with diabetic retinopathy, we see epiretinal membranes. And one of the functions of faricimab is that it reduces the incidence of epiretinal membrane formation in chronic diabetics, which we all know are very important. Is a poor prognostic factor in maintenance of central vision in diabetics. So faricimab, these are patients who received at least one intravitreal injection of faricimab on or after 1st of July 2022. These patients had no concomitant age-related macular degeneration. These were all patients who were 18 years or above in age. Obviously, there was a combination of treatment-naive patients who'd never had any anti-VEGF treatment and treatment-experienced patients who'd had one or more types of anti-VEGF injections in the past. If we look at the baseline characteristics, age, the mean age was 63. I don't know how many of you were present yesterday when I presented the far wide data on AMD. The mean age there was 80. Over here, it's 63 in diabetics. Again, there was a preponderance of male patients when we saw yesterday, slightly above the female population. Here, only 39.5% female patients, the majority are males. The racial, if we look at the racial distribution, the majority, yesterday's AMD data, about 90% were white Caucasians. In this group, 55 or 60% if you include Irish white patients in the category. Don't ask me why it says white Caucasian and Irish white. Irish also white, but this is the way the question was formulated. In AMD data, the others, i.e. Asian, Chinese, African, Caribbean patients, were 4.5%. Here it's 11%. So you can see already the preponderance and the increased incidence of diabetic macular edema in non-Caucasian patients. If you look at the index of deprivation, this looks at the income of the family, looks at where their house, where they live, where the house is situated, the postcode, the level of education, looking at the socioeconomic status of the patient. In AMD, it was almost a 50-50 split, whereas if we look here, there are more patients in the least deprived segments of the community, and that's to do with their diet, their habits, smoking, their body mass index, more obesity in the lower socioeconomic group. So it was a nice snapshot of the demographics and the epidemiology of diabetic retinopathy. Approximately 86% of patients who were switched from anti-VEGF for DMO to aflibercept were using aflibercept or Eylea, which till 2022 had been our first drug of choice after the DRCR.net trials, which showed that center involving vision, when it is 6/18 or worse, Eylea was superior to Lucentis in controlling diabetic macular edema, and Dr. Tariq alluded to that study in his talk earlier. The majority were moved from Eylea, followed by Lucentis, Ongavia, which is a ranibizumab biosimilar available in the UK for the past 2 years, and bevacizumab. So mean duration of anti-VEGF treatment was 3.2 years. Mean number of injections prior to the index injection. Index injection is the very first injection of aflibercept, was 17.4 injections. And duration of anti-VEGF treatment prior to switching these patients over was 3.2 years. Mean number of injections, 17.4. And the number of anti-VEGF agents used in the treatment of diabetic macular edema before the switch, 75% were using one agent, nearly a quarter had used two different agents, like, for example, Lucentis followed by Eylea, while there was a few patients who had used three agents. Incidentally, brolucizumab, which we do not use in UK anymore, is also licensed in the UK for both AMD and DMO. Mean follow-up was approximately 4 months, and they included patients who had received a mean of approximately 3 injections. So 3.6 was the months of follow-up following the index injection in treatment-naive patients, and 4 in previously experienced patients. At least 3 months of follow-up in 50% versus 56.6% in previously treated. 6 months follow-up in 17%. And as you can see, because this is first cut of the real-world data, the numbers fall off in later months. So 99% of treatment-naive eyes and 96% of previously treated eyes remained on faricimab therapy during the whole trial. Visual acuity improved in treatment-naive eyes over the course of the first 6 injections. 42% of naive eyes and 49% of previously treated eyes that were initiated were faricimab at 70 ETDRS letters, which is 612 Snellen visual acuity. So if we look at the baseline visual acuity, treatment-naive eyes, vast number, nearly 42%, had good visual acuity. 49% of previously treated eyes had 70 letters or higher of visual acuity. And if we look at mean visual acuity change from baseline after the index injection, you can see that in the treatment-naive eyes, there's a successive increase in vision with each injection, from 3.4 to 7.7 letters by injection number 6, whereas vision does increase but kind of stabilizes in the previously treated eyes. So the vision gains are basically just 1 letter over the first 6 injections. So far-wide DME is a real-world study evaluating treatment outcomes of faricimab in the UK. This is data from 21 NHS sites taken from their electronic medical records. And real-world data is a really important tool in understanding the response of new drugs, as well as any red flags, any side effects in the real-world setting, using the drug in different ethnicities and different cohorts of patients. These are called post-hoc studies or phase 4 studies, and they're very important, and they're important in understanding the safety and efficacy of any new drug. So at faricimab initiation, approximately 1/3 of the patients were treatment naive. Majority of previously treated eyes were with aflibercept. Vision improvement was seen in treatment naive eyes around 5 letters, which is similar to what was seen in the pivotal trial, Yosemite and Rhine, which was the licensing approval study. And vision was maintained in previously treated patients. If we look at the treatment pattern, so mean treatment interval extended to 8 weeks after the fourth injection, and 99% of naive eyes and 96% of previously treated eyes remained on faricimab therapy. The real-world data did not show up any red flags, particularly any ischemic vasculitis or any severe inflammation. But I've included here, just for the audience, the actual adverse events from the Yosemite and Rhine trial, and that was cataract formation, conjunctival hemorrhage, vitreous detachment, 4% intraocular pressure rise, vitreous floaters, and eye pain. The most serious adverse events were uveitis, endophthalmitis, and vitritis. So immunogenicity of any intravitreal injection is extremely important. And we know that any drug injected into the eye, any protein injected into the eye can potentially give rise to an immune response as a foreign protein. After dosing with faricimab for up to 2 years, treatment emergent anti-faricimab antibodies were detected in approximately 9.6% of patients with DMO. This is not unusual. It is found with other agents like aflibercept as well. The incidence of serious ocular adverse reactions in anti-faricimab antibody positive patients was higher than in those who did not harbor any anti-faricimab antibody patients, so 10.9% versus 4%. Anti-faricimab antibodies were not associated with an impact on clinical efficacy or any systemic toxicity. Both faricimab and aflibercept are well tolerated with low incidence of serious immunogenic responses. I'll quickly show you some data from my own department. So Vabysmo was initiated in July 2022, and some patients were followed up for their 6th injection for this short study. So we always start with a loading dose of 4 injections, 1 injection a month for 4 injections. Our 5th injection is 2 months after the 4th injection. And after that, we use the treat and extend regimen, also called personalized treatment interval, or PTI, for these patients. So you look at the vision central foveal thickness at baseline, compare it to what was the vision and central foveal thickness at the 4-month time interval, and then after the 5th injection. So these 3 indices, these 3 parameters, we then use to decide when the 6th injection is going to be, whether it's going to be Q12, which is 3 months after the 5th injection, or Q16, which is 4 months after the 5th injection. And if we find that we've achieved the best central foveal thickness and the best vision in that patient, then we stick to Q16 after the 5th injection. So we had 25 eyes that we looked at in the initial cut, 10 right, 15 were left eyes. Male to female was 18 to 7 ratio, and again we saw in the Yosemite and Rhine and the far wide data as well, the UK 21 hospital data, male preponderance in this group. The mean age was 57 compared to 63 in far wide. The mean now I've not used best corrected visual acuity. That is what we talk about when we talk of studies. The landmark trials are best corrected visual acuity. I've used best recorded visual acuity. And in the US real world data, which I'm going to present later in the day, they use the term best documented visual acuity. The reason being, in trials, every patient is actually refracted and uses up-to-date glasses. Whereas when they come to our busy clinics, sometimes they forget to bring glasses. So some of our visions are recorded with pinhole, and others with glasses which are perhaps not up to date. So best recorded visual acuity was 68 ETDRS letters, the range between 35 and 95. We use a cutoff of 696 for treatment in wet AMD. In dry AMD, there is no cutoff. Sorry, in DMO, there's no cutoff for vision. The only parameter that we use for initiating treatment is a central foveal thickness of 400 microns, which is the same across the board for any VEGF agents, whether it's Lucentis or aflibercept. They have to have center involving diabetic macular edema with 400 microns. Average central foveal thickness in this cohort was 433 microns, and maximum ranged between 400 to 653. So mean best corrected visual acuity and the number of injections, you can see that there is a slow increase in vision from 68 to 74 letters, slightly less than what was seen in far wide. In far wide UK data, it was between 6 and 7.7 letters, but that probably is an indication of the low socioeconomic group patients that we see in our clinics. There was a reduction of central foveal thickness, especially in the first 4 or 5 injections, and then it kind of stabilizes when they enter the personalized treatment interval duration after the 5th injection. So in our case, about 170, I think it was, a reduction in central foveal thickness. In Yosemite and Rhine, it was 204 and 197 microns, respectively. So treatment interval after 5 injections, we were able to extend to 8 weekly in 90% of our patients, and 12-week or Q12, as we call, 3 monthly injections in more than half of our patients. And this just shows a mix of the spread of patients. So 26% patients are here. We were able to extend the injections. And then there was a mix because, the majority of our patients were treatment experienced patients. No red flags were seen in our cases. It's a short study, but no red flags were raised in the far wide, which had thousands of patients in its database. So in conclusion, visual acuity increases in terms of best corrected visual acuity. Central foveal thickness decreases with the use of faricimab. 90% of the patients were extended past Q8, and I've used Q8 because that is what we use. That's the regimen we use for Eylea, 2 monthly injections. There were no adverse events, and in September, National Institute for Health and Care Excellence in UK has given license to faricimab for retinal vein occlusion, and I've already enlisted my first patient. So we'll see how it compares with Ozurdex, which is my drug of first choice at the moment for retinal vein occlusion. Thank you very much.
Thank you, Dr. Shehzad Shafkat. Now, Professor Hamid Mahmood Butt, his presentation is on PRP versus intravitreal injections, how the laser works. I'll request all the presenters to please stick to the time. The time allocated is 9 minutes. So kindly please try to finish up within 9 minutes.
Bismillah ar-Rahman ar-Rahim. Thank you, Professor Shehzad Shafkat. I'm lucky to be your class fellow for your robust data. And coming to our scenario, as we were discussing yesterday, we have to keep a balance of the things. So in that perspective, this is largely a conceptual talk and more so targeted at the PGs. So, kitne PGs baithe mein hain? Can you raise your hands? So it is basically designed for you and for us as a continuing medical education. So I would like you to give us your feedback at the end. Few of the landmarks said it's very humbling that diabetic retinopathy was first described in 1856 when the first ophthalmoscope was the biggest revolution, having a look inside the eye. So historically so humbling. It's not a very, it's a 1.5 sadi ka kissa hai. Zyada nahi. Or then there are a lot of trials in between. The 2 trials that I would be mentioning on which we started our clinical training was the DRS and ETDRS, which made us do the in 1978 the DRS and the 1985 ETDRS. That happens to be our year of graduation also. So we are ETDRS graduates. These 2 actually made us go for the lasers. For pan-retinal ablation, for proliferative diabetic retinopathy, and focal photocoagulation, and then as extension, grid photocoagulation for diffuse diabetic macular edema. And then in came the anti-VEGF. But don't forget, and what we forget as, that is the message that I want to give to the trainees, the recommendations of DCCT and UKPDS. Please do mention to your patients that you have to keep your hemoglobin A1C between 6 and 7. हम हर चीज़ एडवाइस कर रहे होते हैं. एक छोटा सा उन्हें कहें जी आपका हेल्थ इंडिकेटर है. ये मैं तो उन्हें कहता हूँ जी आपकी गाड़ी का इंडिकेटर अगर बगैर इंडिकेटर लगाया you turn right and left, what will happen? So you'll have a bang. So before instituting anything, PRP or focal or anti-VEGFs, do tell your patients to watch their blood pressure and their hemoglobin A1C. Make it part of your communication skills to the patient at the end of consultation. And this is the disease severity, where we travel from mild to moderate to severe and to PDR. And I like this photograph from the journal Eye. On the left side, you have a lot of capillary dropout areas. A lot of capillary dropout areas, and then that drives the VEGF for the neovascularization. Now, there is no treatment in the world which can reperfuse this tissue. Full stop. That's my understanding. And then you see the same thing happening in the OCT angiography, which is the wide field. And this I've already talked about, so I'll not, in the interest of time, I'll just move forward of what I have talked. But this is the slide for the trainees. वो हमें कहता है जी या पार्ट 2 के एग्जाम में पूछते हैं PRP काम कैसे करती है. So a lot of answers come to us. Well, basically, you are actually debriding the outer segments of the rods, and in the process, the nuclei also go. So, and it was very humbling for me when I was writing, preparing for this talk, that the rods and the cones have the highest oxygen consumption in the body. More than the brain, yet it has no direct blood supply. So it is such a conceptual insight for me कि जहाँ सबसे ज़्यादा ऑक्सीजन की ज़रूरत है वहाँ डायरेक्ट ऑक्सीजन है ही नहीं, सप्लाई ही नहीं है. So in the process, when you do and debride the outer segments, you get the oxygen going from the choriocapillaris and supplying the inner the segments, and then it also transfuses to the inner retina. The inner, there's a watershed zone somewhere in between where there is oxygen deficient from the outer and inner retina. Only the inner 1/3 has retinal capillary circulation. Yes. And when you're doing a pan-retinal ablation, please do gentle burns. You're only targeting a gray-white lesion because you're targeting this tissue. If you give a full chalky white, you're going to burn the whole retina. And that is where you get extensive visual field defects. So you can actually induce field constriction and tunnel vision if you give very heavy burns. And the lesions are actually visually calibrated as to be just, now they recommend just visible, just creamy white lesions. And this is something would be in an extreme example. And this is what makes us, you can have an ascending optic atrophy. So people who get an aggressive, आपने किसी की नज़र बचाने के लिए ट्रीटमेंट की है ना, तो आप उसकी नज़र अगर ट्रीटमेंट के थ्रू डिस्ट्रॉय कर दें, तो that is not the right thing to do. So for us to understand that PRP is a very powerful tool, so you have to use it very, very judiciously and in the proper calibration and the proper dosing. And then came the era of the anti-VEGFs, and that is where Shahzad took us in a very, very evidence-based manner. And we were discussing in yesterday's consultative meeting of the medical retina that the strength of evidence-based is data. So if we cannot generate our data, we actually make ourselves literate. And this is the power of this forum, where our the foreign speakers who are of Pakistani origin are a huge resource for us and a linkage in knowledge transfer. So the summary of this protocol S, where we compared whether we should be doing PRP or whether we should be doing anti-VEGF, came in one simple graph. Can you interpret this graph for me, anybody? It just, the bottom line is If you do PRP in the proper patient, or you give anti-VEGF injections in the proper patient, in the proper manner, and there is no loss to follow-up, that is very important, you get similar stabilization of results at the end of 5 years. But in between, wherever in PRP group, there was macular edema, diabetic macular edema, the patients were not denied treatment because it's not ethical to deny an established treatment. So for me, this graph makes you think twice in our limited economic scenario and setup and resource-starved environment. Don't throw away your lasers. Laser is still the gold standard of proliferative diabetic retinopathy in our setup. And I would like you to focus on the last bullet. Individual patient factors such as anticipated potential for maintaining scheduled visits, number of visits, cost, and systemic health should be considered when choosing a treatment for proliferative diabetic retinopathy. So I think that one, as a policy statement, we should take it for one of the latest world standard protocols for the treatment of proliferative diabetic retinopathy. At the end, whatever you're doing, either PRP or anti-VEGFs, retinal recirculation is not going to be re-established. आपने जो उसके फ्रेश एरियाज ऑफ इस्कीमिया हैं उनको प्रिवेंट करना है, एक नया ऑक्सीजन डिमांड एंड सप्लाई बैलेंस क्रिएट करने के बाद वो सिर्फ आप गुड डायबिटिक कंट्रोल एंड गुड हाइपरटेंसिव कंट्रोल से ही इस्टेब्लिश कर सकते हैं. सो दैट इज ऑल्सो द मैसेज फॉर द ट्रेनिंग्स. So they actually looked at the retinal circulation through OCT, wide field OCT angiography and wide field FFAs, and again there was no documented re-establishment of the retinal circulation. So what should we be doing? Final. The pros, can we use them in combination? I think that would be the best approach if we use the two treatments in combination. So the pros would be faster neovascular regression rapidly with anti-VEGFs may protect against acute incident DME or exacerbation of pre-existing DME. Place PRP for permanent treatment to save visual acuity. May have reduced vitreous hemorrhage and fractional retinal detachment if patients do not return for timely follow-up. May reduce anti-VEGF treatment burden. And the cons would be that the anti-VEGF will not necessarily diminish incident DME that develops later in follow-up if combined with PRP. Anti-VEGF will not necessarily reduce visual field loss noted with PRP. Anti-VEGF will not necessarily reduce fractional retinal detachment and need for vitrectomy if combined with PRP. And a one-and-done approach. Yet 50% require supplemental PRP, and anyone lost to follow-up may do poorly irrespective of initial management. Some eyes with PRP still go blind. So हम ट्रीटिंग फिजिशियंस जो है ना, हम टर्शरी केयर में चल रहे होते हैं. किस पेशेंट में विट्रेक्टमी करनी है, किस पेशेंट में फोटोकोएगुलेशन करनी है. But we must shift our focus as a community, as a profession, to primary and secondary levels also. Do talk to your patients about good glycemic control, good hypertensive control, and annual dilated fundus examination. मेरा ख्याल है पब्लिक हेल्थ में हम मेडिकल रेटिना एसोसिएशन ऑफ पाकिस्तान एंड OSP, और जहाँ पे भी मैं जाने की मेरी होती थी कोशिश, आप अपने डिपार्टमेंट्स में, अपने क्लिनिक्स में, अपने GP दोस्तों को ख़ास तौर पे, देयर इज़ अ ह्यूज नेटवर्क ऑफ जनरल प्रैक्टिशनर्स एंड फैमिली डॉक्टर्स, उन्हें कहें कि आप साल में एक दफ़ा आँख की पुतली फैला के आँख के पर्दे का मुआयना कराएं. और ये एंड इट्स इवन मोर इम्पॉर्टेंट इफ द डायबिटीज़ इज़ मोर देन 10 years. of duration. Uh, I distinctly remember at the end, like a storyline, one of our very senior professors and was talking to after the surgery he conducted. He used to do with vitrectomy with indirect ophthalmoscopy, and Shahzad would recall the gentleman by the name of Professor Scott, John Scott. So after one of the surgeries, वो जब करके बाहर निकला थिएटर में, तो he said, प्रोफेसर साहब ने उनसे कहा कि you've done a wonderful surgery, you've done a marvelous job. क्योंकि इंडायरेक्ट से विट्रेक्टमी करना फॉर इट हमारे लिए भी बहुत बड़ी चीज़ थी, एक नई चीज़ थी. तो उन्होंने कहा, well, this is something I should not have been doing in the first place. अच्छा, अब अंग्रेजी हमारी थोड़ी सी टाइम लगता है समझने में, तो उन्होंने कहा नहीं, उन्होंने कहा शायद मैंने कसर नफसी से काम लिया, तारीफ थोड़ी की है. तो उन्होंने दोबारा तारीफ की, उन्होंने कहा जी इट वाज सच अ मास्टरली जॉब. और फिर उन्होंने फिर वही जवाब दिया, वेल दिस इज समथिंग आई शुड नॉट हैव बीन डूइंग इन द फर्स्ट प्लेस. और फिर एंड थोड़ा सा पॉज देके कहने लगे, इफ समबडी हैड प्लेस्ड प्रॉपर लेजर ट्रीटमेंट आई वुड नॉट बी ब्रेकिंग माई बैक फॉर 3 hours. तो इसलिए इट इज़ वेरी इंपॉर्टेंट कि आप अपने पेशेंट्स को जल्दी कैच करें थ्रू प्राइमरी सेकेंडरी प्रिवेंशन. इट्स अ ह्यूज पब्लिक एंटरप्राइज जिसकी तरफ हम बात कर रहे हैं, लेकिन हमें ये ज़रूर ये एंगल रखना चाहिए अपने ज़हन में. अपने अंडर ग्रेजुएट टीचिंग में जब हम 4th ईयर को पढ़ा रहे होते हैं, अपने पीजीज को, पब्लिक में जब जाते हैं, अपने पेशेंट्स को अपने क्लिनिक्स में, वी मस्ट गिव दिस मैसेज दैट प्रिवेंशन इज़ बेटर देन क्योर. थैंक यू वेरी मच.
Thank you, sir. Now, Dr. Mariam Shamim. Her talk is on diabetic retinopathy. Dr. Mariam Shamim. Sir, 1 minute. Professor Tariq Aziz want to give the shield of leadership to one of the medical retina.
Sorry to disturb you in the middle. Hamid bhai, आपका माशाल्लाह excellent contribution रहा है all over the places, and आपने जो मेडिकल एजुकेशन और ट्रेनिंग का जो दिया जलाया हुआ है वो इसी तरह जलता रहे, और आपकी ट्रेनिंग के अंदर हम इसी तरह सीखते रहें. यू आर रियली एसेट टू अवर ऑप्थेमोलॉजिकल सोसाइटी एंड ऑफ कोर्स विद द मेडिकल रेटिना. The Executive Bureau of the Medical Retina has decided to award you the Leadership Award. So may I request you to come here and receive the award. May I request the Mazhar Qayyum, the past Central President, to hand over this award to Hamid Bhatt Sahab. Ladies and gentlemen, Hamid Bhatt Sahab. Today I came to know कि शहजाद और हामिद भट्ट साहब क्लास फेलो थे. चलो जी, ये भी बड़ी अच्छी बात है. नाइस टू नो.
Congratulations, Professor Hamid Bhatt Sahab.
Mariam, the podium is yours.
Thank you, sir. Dr. Mariam Shamim.
Assalamu alaikum. I am Dr. Mariam, and I feel like my presentation is just in continuation with what Dr. Hamid has said already. So I'm just here to share my experience in diabetic retinopathy, working as a public sector ophthalmologist. And I feel like that diabetic retinopathy is going to be, or maybe it is now, the next epidemic in Pakistan. So being a poor country, one would think that Pakistan should not be the #1 country in the world to have the highest population of diabetics, and also should not be the highest cause of NCD of deaths before the age of 60 years. And this vision threatening diabetic retinopathy of 28.2%, and this survey was conducted in 2017. Now I don't know कि ये कितना increase हो चुका होगा. So what is the reason?
वो होती है, लेकिन वैसे ये बेहतर रहती है. नहीं, कोई जख्म किसी किस्म का हो जाए तो वो फौरन ठीक हो जाता है. वैसे तबीयत सेट रहती है ये बात.
लेकिन मैंने शुगर का इलाज कराया हकीम से, अभी जो है खत्म हो गया.
दवाई बोला मेरे पास कुछ पैसा नहीं है, अब हम नहीं ले सकते, पहले धंधा हो जाएगा, कुछ भी हो जाएगा ना, नहीं ले सकते।
हम बहुत दूर से आते हैं, गरीब लोग हैं, हमारे पास इतना खर्चा नहीं, आने जाने का 3500 रुपये किराया लेता है लोरा में होटल का।
दवाई तो ले रही है, फिर भी बढ़ रही है।
And this is mainly the reason that we are dealing with this horror show on daily basis. These are all the pictures of my patient. So the biggest challenge that we face is lost follow-ups. We have a diabetic counselor in our hospital, and when she calls and follow the patient, the number one reason the patient does not follow up is a lack of understanding of the disease seriousness. And then there are indirect costs involved. Although we are treating the patient for free, but then there is travel costs, lost wages, and co-mobs. And then these diabetic patients are continuously stuck in this cycle of visual loss, financial burdens. They are burdened on their family. There is amputations, co-mobs, and depression and anxiety, and they just then don't care about their visual loss. So what should be done? We must be doing something. We are doing these things. We have NGOs, numerous NGOs, trust hospitals. We have some initiatives like Sight Saver initiatives. We have a national eye health program. And but the most challenges that we face is inconsistent funding, lack of equipment, and lack of rural coverage. So the proposed solution, the number one solution that already Professor Hamid has pointed out, we don't have national policy for diabetic retinopathy. There's a wonderful document, and it was made in supervision of Professor Asad Awan, and it has incorporated the screening of diabetic retinopathy in primary and district level, but we need implementation of that. We don't have any implementation. So it needed to be the diabetic retinopathy screening and awareness. It should be in the primary care. And then the district hospitals come, and then they refer to the tertiary care where we are sitting for the treatment. And another important thing, which we were talking about yesterday also, we don't have a national database. We don't have the prevalence of diabetic retinopathy even in Pakistan. The last survey was conducted in 2017, and now there is nothing. We are not doing anything. We are not preparing our data. We don't know the prevalence. We don't know the risk factors. We don't know कि जो वेस्ट में ट्रीटमेंट हो रहा है उसका हमारे पेशेंट्स के ऊपर क्या इफेक्ट हो रहा है. We don't know that, and we are not doing anything about it. And I think it is the most important thing that we should be doing. There is another important thing that we should be partnering up with the GPs, and secondly, the district units. Tertiary care हमारे पास बहुत सारे हैं, कराची में भी, and all the main cities. We can adopt district centers in ourselves, जहाँ हम उनके पेशेंट को स्क्रीन आउट कर लें, वो अपनी स्क्रीन आउट करके हमारे पास भेज दें, and then we treat. Or once in a while, once in a month, or once in 3 months, one of us can visit those areas and sort of screen out those patients. Then professional training is very important of the district ophthalmologists and optometrists, and we should also be collaborating with international foundations for our trainings. Then role of AI is very important. There's a wonderful study by Dr. Aman Siddiqui on AI screening, and it is very helpful. And if we incorporate on this on the national level, I think it would be wonderful. So in conclusion, as Dr. Hamid has already said, हम यहाँ पे सारे मेडिकल रेटिना एसोसिएशन के हम सब बैठे हुए हैं, OSP, फेडरल के सब बैठे हुए हैं, and I think we should be taking the initiatives. So this is a saying by JFK. If not us, then who? If not now, then when? Thank you very much.
Thank you, Dr. Mariam Shamim. Now, Dr. Abdul Sami Maiman for his presentation on role of OCTA in diabetic retinopathy, where we are and where we are going in 2025. Dr. Abdul Sami Mem.
So thank you very much, Dr. Jamal. So today I'm going to just present the role of the OCTA in diabetic retinopathy. I'm really thankful of those people who just allow me to use their stuff. So this is the pre-test if the postgraduates here. कोई postgraduates हैं? एक चले दो एक भी बहुत है चले look at here. So we are going to quick because time is very short. So these are, so at the end you can find the answers as well. It's the second question. And this one is the third. So before going to the actual the presentation, I would like to stay 1 minute to just to discuss the principle of the OCT. So OCT is really very important investigation nowadays, and OCTA as well. FFA also very important test and still gold standard. But because nowadays, because it's invasive, so people more prefer to do the non-invasive investigation. And it's really more awake for diagnosis of the peripheral retina, not for the macular pathology, because after the anti-VEGF, it really doesn't matter what kind of the CNV or what kind of the macular edema. So we prefer to do the OCT and OCTA. So what is the role of the OCT in diabetic retinopathy? So still it's limited role in the diabetic retinopathy, but we need to just find out these few questions in our presentation. So principle of the OCTA is really simple. So whenever we do two OCTB scan exactly the same place, we just have one question arise. Is there any difference? So answer is yes. Then another question arise. Is there anything moving? Then again answer is yes. But what else? The volume increase. So here you can see. So it's blood flow, basically blood cells. So to more understanding, look at this picture. This is the schematic view. Look at this picture. The top one, we just find out the difference between two pictures and mark the red. So OCTA exactly work the same way. You can find out this cluster of the OCTB scans, just find the difference between them and mark the red. And here you can see the beauty of this technology. You can find out these on-fast images. These are very small but beautiful images. You can see this depth encoded. We can just find superficial, deep, outer zone, and the choroid as well. So let's move our presentation. I already told the role of the OCT is limited, but we can find out these questions. So microorganism. So yes, we can just find out the microorganism by the OCTA. But you can see in the FFA, we just found more the microorganism. So to understand this phenomena, you can see this. एक pre-test के अंदर मैंने ये भी question डाला था. So look at this picture. So what happened over here? When we did this scan, we just missed this data because due to this slow blood flow. So to overcome this limitation, we have different software. So now we can just find out the high speed, low speed easily. Then another question arises here. Can we identify the neovascularization or air mass, or we can differentiate? Answer is yes. Look at this picture. You can see over there a lot of the dead trees or maybe the juicy vessels here, and also the non-flow areas. And if we go here, compare with the OCT and FA, you can see there is some abnormal vessels here. But you can see in the flow overlay, the blood circulation inside the retina. and here you can see no leakage. When we move over here, of course, clinically you can find these vessels clearly. Again, the flow above the retina. Again, you can see the leakage here. But look at this picture in the orange block. You can see it's some abnormal here. You can see this blood flow above the retina. But look here, no leakage. So this is the beauty of this technology. Then let's move over real world cases. You can find out this lady visual acuity almost 100%, and you can see there is some abnormal vessels here. Another 66-year-old patient, you can find out the flow above the retina. Here you can see, because only one resident here, so if any resident just like interpret for me. Look at this picture over here, something abnormal here, some here, some here. But when we do, maybe new vessels, but when we do here, look at this picture, maybe new vessels, but look here and here, the flow overlay inside the retina. So these are not new vessels. Same picture over here. Another patient, easily we can detect clinically. Maybe say, Doctor Sahab, ye to वैसे ही नजर आ रही है, क्या जरूरत है? Look at this picture again. Over here, what happened over here? These are some abnormal vessels, but again, no flow above the retina. So that's the beauty of this technology. So can we monitor the disease? Yes, we can monitor the disease. After the injection, you can find out no vessels here easily. Then can we predict the disease or not? So yes, look at this picture. This patient just got a lot of the injections, and after injection, visual acuity improved. Then he just like गायब हो जाते हैं. Of course, whenever he just come and ask, Dr. Saab, और कितने injection लगेंगे? So look at this picture. Visual acuity improved. Everything's okay. After a few months, come again. Then again, like Dr. Saab, और कितने injection लगेंगे? So look at this picture carefully and park in your mind. We just discussed later. Because after the few injection, almost normal, but visual acuity not improved. So we can just discuss later. So let's come over here. So what is the clinical biomarker of the DR? Any resident? Professor Hamid already told us the chemical biomarker, because without the A1C, like a incomplete treatment. So it's like a lot of the clinical biomarkers. So macular vascular density is one of them, and we need to just find out this macular vessel density easily with all the machines nowadays. So every machine their own algorithm to just like calculate this vascular density. This is the data. So we can just find out the non-diabetic and the diabetic population easily. Then we can we identify the macular ischemia? Yes, we can easily identify the macular ischemia. Then let's move the same patient. Now the visual acuity was not improved. And patient परेशान हो गया कि पहले तो visual acuity injection के बाद improve हो जाती, तब क्या हो गया डॉक्टर साहब? So look at this picture carefully. So the vessel density is very important part. And you can see decreased visual acuity more associated with the decreased vessel density in the superficial and deep capillary plexus. And we also know the drill is also the part of this. So these are the insights from the OCTA, and in future, all these machines are inbuilt with the AI algorithm, and inshallah, we will just find out in future more opportunities for the screening, diagnosis, and monitoring the disease. And of course, the technology, biotechnology and AI and genetic engineering may be a change with the better outcome in future. Thanks.
Thank you, Dr. Abdul Sami Mehman. Now, Dr. Sidra Riaz the presentation on role of suprachoroidal triamcinolone injection in refractory diabetic macular edema. Dr. Sidra Riaz.
Good morning, ladies and gentlemen. Diabetic retinopathy, we are very much concerned about diabetic retinopathy because in 1991, we were not in the first top 10 countries where the diabetes was prevalent. Of around 2000, we were at number 7 in diabetic population, but unfortunately now we are at number 3 according to the statistics of 2023. So this diabetic related ocular complication, we are very much concerned with it and its treatment. One of a affordable way to treat diabetic macular edema is with the help of this suprachoroidal triamcinolone. How diabetic macular edema develops? We all know that number 1 is the uncontrolled glycemic control, which will lead to this formation of macular edema. And number 2, these are certain inflammatory mediators, including VEGF-A. So we need to control the glycemic control. Number 2, we need to handle with this inflammatory pathway through which we can temporarily control this permeability of small vessels around macula. So actually the blood retinal barrier is very much affected and that is being broken. This is a complex pathway by which hyperglycemia along with hypertension and hyperlipidemia leads to inflammation, breakdown of blood retinal barrier, breakdown, and then drainage dysfunction, oxidative stress, leading to macular edema and leakage around macula. How we can treat this diabetic macular edema? The utmost important is metabolic control. Number 2, anti-VEGF, we all know. Expensive but effective treatment for diabetic macular edema. Third one is intravitreal steroid. And other route is suprachoroidal steroid because the intravitreal steroid, they have certain complications. And if not improved by all, the PPV, pars plana vitrectomy, is the ultimate treatment option to treat this macular edema. The mechanism of action is very simple, that it is intermediate acting triamcinolone is intermediate acting steroid, which leads to anti-inflammatory effect by inhibiting the phospholipase A2, which will lead to prevention of further prostaglandin formation and leukotrienes. Another role of triamcinolone is that it has certain anti-inflammatory role because it works on VEGF-A2, which is the main mechanism of action of all anti-VEGF we use intravitreally. Advantages, it is affordable, and especially for our population where we are also suffering from ban on Avastin, and it is effective in decreasing central macular thickness. Vision is improved from 10% to 80%. No cataract formation, no IOP rise issue with this if we use it as suprachoroidal route, and no risk of adverse vascular systemic effects like we see in angina or other cardiovascular events seen with anti-VEGFs. Disadvantages are, of course, the local ocular side effects, like you may see the whitening formation or whitening plaque. It is not a permanent solution. Either we have to control the diabetes or we have to give repeated injection. People come, they get their injection, they get better, but again because of poor control or they again develop this macular edema. And it is also ineffective in infective etiologies or infective uveitis. Procedure is very simple. We all use in your OPDs and OTs, that's 30 gauge 1 cc syringe is used, in which we take the 0.1 ml of this triamcinolone injection. Needle is usually withdrawn from granula, and granula is usually cut just to have 1 millimeter tip so that we can use it in supratemporal quadrant. And eye is draped in the usual routine as we do in cataract surgery. Needle is slowly withdrawn and carefully so that there is no slippage seen around this. Here you can see the supratemporal quadrant is used. You can use in all 4 quadrant, but according to the studies, it is most painful quadrant to do intravitreal or any suprachoroidal route is infranasal route. And according to studies, the supratemporal quadrant is relatively safe, easy to access, and relatively less painful as compared to other 3 quadrants. Ready-made syringes are also available now. Here you can see the tip is exposed only. It is around 0.8 to 1 millimeter, and you can use it easily after filling with triamcinolone. The macular edema shows resolution which starts from 2nd week, and usually it ends on 6 to 8 weeks depending upon your good metabolic control of diabetes. Results of our study were very hopeful. We have 22 patients in which it was used. So the best corrected visual acuity was from 660 to 612, and worst was from 660 to 636. Central macular thickness was decreased in all patients, and a mean number of previous injection was also notable in this case, because these mostly the cases we enrolled in this were refractory macular edema which were not responding to anti-VEGFs. This is the published article in PGO. Thank you very much for your attention.
Dr. Sidra, please stay there. Now, the Medical Retina Association of Pakistan is going to award the leadership award to Dr. Sidra Riaz in recognition of a great contribution in medical retina, especially in the study of the diabetic retinopathy. I request Professor Shakib Anwar, President, Medical Retina Association of Pakistan, to come forward and present this shield to Dr. Sidra Riaz.
Assalamu alaikum. Before I give this award to Dr. Sidra, she has been very vibrant and very active, and the Medical Retina Executive Bureau and all the other members, including myself, we have been seeing her performing very well in medical retina indifferent. For the last 3 years, we have been seeing her actively involved, and she's a very accomplished young professor who has done her FCPS and FRCS. She has trained in LRBT under Dr. Qazi at Lahore, and she has done multiple international presentations as well as many national presentations. There are about 39 publications to her credit, and we wish her the best in her future life. And I would request our the patron of Ophthalmic Society of Pakistan Federal Chapter to please come forward and award this shield to Dr.
Thank you. Now, the last speaker, I think, is Dr. Amash Akil. His presentation is on Retina for the treatment of wet AMD, real-world data from University Hospitals Birmingham, NHS Trust. Dr. Amash Akil.
Assalamu alaikum, everyone. My name is Dr. Amash Akil. I'm a medical retina fellow at University Hospital Birmingham, and the topic of my presentation today is actually something which builds up on Dr. Shehzad Shafqat's presentation and a lot of the other talks that we're having here today as well. So it's on the treatment of wet AMD, and it's about Vabysmo or faricimab and its real-world data from my institute. I have no conflict of interests. So, as you know about the basic molecule, it's a bispecific antibody, and it binds with VEGF-A and angiopoietin. And some of the research done on it is in the TENIA and LUCERNA trials, and is approved by NICE for wet AMD around 2022. And in a lot of the NHS trusts is being used second or first line to treat wet AMD as well. So the protocol that we used in our trust was a loading dose of 4 monthly injections, and with corresponding OCTs and clinical exam data collected along the way. So wet AMD is something which is more in Caucasian people than in Asian people, and there's like 1 million eyes involved in the UK. And as you all know, it affects the eyes in a series of ways, and the visual sequelae is often a chronic debilitating problem which leads to loss of the central vision, and it is something which causes that person to lose a lot of quality of life years as well. So the purpose was basically to review our injections between July 23 to July 24. It was a year of data collection, and we were evaluating the safety and effectiveness of faricimab. And also it was an audit to look at if the current practices meet the recommendations, and we were hoping to improve and make adjustments along the way. So the resource that we used for data collection was the Medicide EPR, which is the major electronic medical records used in my trust. And for OCT, we had the Heidelberg Spectralis. Data collection included date of birth, hospital ID, injection number, drug site, best corrected visual acuity, and also macular OCT parameters such as central foveal thickness, volume, maximum thickness. And the outcome was improvement of BCVA on OCT during the audit period, visual acuity and OCT changes over the course of the injection calculated, and any adverse events reported. So we had a total of 100 eyes from 96 patients, and 60% of our patients had a female preponderance. So the first patients in the UK had injection, this first patient in our trust had injections as early as June 2024. And we had 6 treatment naive eyes, and the interesting part of the study is that majority of the patients were actually drug switch eyes. So we had a combination of legacy treatments, Eylea and Lucentis, before these patients were switched to faricimab. So majority of the patients had a Wilcoxon rank sum test as the statistical analysis used to compare between the different doses. And as you can see from the whisker plot, the central subfield thickness during the course of the faricimab treatment improved over the 4 loading doses. One interesting thing to note here is the increase in the central foveal subthickness between the initial OCT and the loading dose is because there is a delay between listing the patients for injections and after which they get the first injection. So doing an audit is one of those things which sort of exposes these kind of things in the system. And now these patients are listed more quickly for their first injection, and any delay would cause an increase in the CST if there's a delay or gap between a switch from the legacy to faricimab treatment. So the volume on OCT during the course of the faricimab, as you can see, there's a gradual improvement over the course of the 4 injections with eventual stability. And as you can see from the whisker plot, that the standard deviation is similar along the course of the injections. BCVA stabilization during the course of the treatment was fairly consistent. There wasn't an increased decrease in the vision during the course of the treatment. It was fairly consistent along the way. So here are some of the real world patients, as you can see from the first 2 slides. So there's an improvement in these patients after the loading doses, and these are basically treatment naive cases. And as you can see, there is consistent maintenance of the macular volume and also the OCT thickness in drug switch cases as well. So the result and recommendations from this audit is only 1 patient reported endophthalmitis like signs and symptoms. No particular adverse events were noted for the patients who were switched. Real world data shows less impressive results compared to the landmark trials, as other confounding factors such as cataract and dry eyes, smaller sample size as well. The UK far right study provides real world data. However, we are not compared our results to theirs because of significant methodology differences. And the far right study, unlike ours, did not utilize a loading dose of 4 injections. So the second audit cycle is already underway, and we're looking at the effectiveness of faricimab and longer treatment dosing intervals from 8 to 6 weeks. And we have a separate cycle being run for switch and treatment naive patients with a more meaningful comparison to the pivotal trials. Thank you.
Thank you very much, Dr. Amash Akil. Now, is there any questions from the audience, from the way different speakers? I have one. Yes. Yes, Dr. Shehzad Shafqat.
Just want to make a few comments, a few points. Going back to Tariq Saab's presentation, the first presentation, he mentioned about different types of lasers. So the laser that we use in the department is Pascal, which is a pattern scanning laser. It's like argon laser, but he pointed out, and Professor Hamid Bhatt also alluded to it, that the important thing is to give small burns, and small burns and nanosecond durations are very, very important. Pascal covers the retina very quickly because you can do like large 16 or 24 burns in press of a single button. Secondly, the importance of making grade 1 burns, which are very gentle, creamy burns. They don't expand that much. Now, in pigmented races like Asians, African, Caribbeans, you get a lot of laser creep. That's the term used for enlargement of the size. So your laser burn, you may give 200 micron burn, but in 3 years' time, the same burn will be 400 microns in size. And if you give it very close to the fovea, it will affect the fovea and the vision will go down permanently. Similarly, large burns means low loss of visual field and driving visual field. I don't know whether you do it here or not, but in the UK, everybody has to have an Eastman binocular visual field for driving. And all patients who have laser have to inform DVLA that we've had laser. So their optician will make sure, or the hospital will make sure that they have an Eastman visual field. So you can have 6/6 vision and still be told you can't drive because you have lost visual field. And Eastman visual field is done in sort of 40 degrees vertical and 120 degrees horizontal. And if you have 3 or more contiguous points of loss of vision, that is considered to be a significant scotoma, and you're not allowed to drive. Tariq Saab also mentioned the yellow laser. Now, the yellow laser is 577 microns. It's a very safe laser, especially when you are working close to the fovea because xanthophyll doesn't absorb it. So it's mostly absorbed by the hemoglobin. One other point I wanted to mention, Professor Hamid, but was very eloquently describing the site where the laser burns act. So what you want to do is to reduce the metabolic load, the oxygen demand of the retina. And the most active part of retina is the RPE and the nuclei of the photoreceptors. That's the only area you want to destroy legitimately in a very controlled way. So it's a controlled destruction of the area. And finally, just want to make a point, when you're doing PRP, the most important area that you want to treat is the junctional zone between the vascularized and the non-vascularized retina. This zone you must treat, and sometimes it lies just outside the vascular arcade, and sometimes it lies between the vascular arcade and the equator of the eye. So this zone must be incorporated in your laser. If you avoid this area, and you don't treat this area, then VEGF is still going to be liberated. Other cytokines are still going to be liberated in the eye, and you will not get the maximum benefit of panretinal photocoagulation. One final thing, some of the newer drugs that are coming in the management of diabetes and our physician colleagues are very keen to use GLP-1 analogs, which are glucagon-like peptide-1 analogs. I'm sure they're available in Pakistan as well, because people with high body mass index, or people who are obese and diabetic, these drugs are very, very effective in controlling their diabetes as well as their weight. So they're very popular, and sometimes people buy them off the internet without their physician knowing, just to lose weight. They are now causing a small rise of diabetic maculopathy in the population in the UK. And we've been informed by the health regulatory authorities that any person who started on GLP-1 analogs, they're called Ozempic or Wegovy, and Mounjaro. Mounjaro is a subcutaneous injection given once a week to lose weight. And these patients can have worsening of their diabetic maculopathy for the first 6 months of the use. Also, now it's known that the cholesterol-lowering drugs, the older ones, the first generation drugs, were lipotropic cholesterol-lowering drugs, simvastatin and atorvastatin. They actually make diabetic maculopathy worse. But the newer ones, the non-lipotropic ones, rosuvastatin is a safer one to use in diabetic patients to prevent diabetic maculopathy getting worse. Thank you.
Abdul Sami, you want same question? Regarding the presentation of Professor Hamid Mehmood Saab, I would like to say that laser has a still role. There's no doubt. But the thing is that in PRP, the PRP is the treatment of choice in proliferative diabetic retinopathy. But when there is clinical significant macular edema, then macular thickness, when you work on apply the laser or macular grid or whatever you want to do, so it sometimes it does not work because there is severe type of the edema on the part of the macula. So it is better to reduce the macular edema with the help of intravitreal steroids or intravitreal anti-VEGF, and so the macular thickness becomes normal, and then you perform FFA or OCT angiography, and you see that if there are certain leakages, then you can apply the focal laser on those leaking areas. So laser has a still role in diabetic retinopathy. It has not become obsolete, but the thing is that where you have to make the place for the application of the laser so that it should work. Thank you very much.
Regarding the laser, thing called this thing that's called endpoint management. So do you do the endpoint management for the macular edema, or do you apply the full threshold burn? Yes, sir. I have this question actually.
So Pascal has EPM, or endpoint management. So what you do is you go outside the vascular arcade and do a test burn. So you find a grade 1 burn, and you know, so this is the parameter for this particular patient, for this amount of pigment in the RPE. Let's say you need 150 milliwatts to produce a grade 1 burn. So you press the endpoint button, it will reduce the output, it will shorten the pulse duration, and then you can go very close to the fovea safely. No, just by pressing endpoint, it will reduce both exposure time. It's still a continuous laser, so this is the difference between Pascal and micropulse. Micropulse is intermittent, whereas this is continuous. Both the idea of both is to burn the retina as little as possible and to get as close to the fovea as possible. So, for example, in CSR, you can treat over the center of the umbo as well. But because you're using because it's low intensity and low duration, it almost becomes like a cold laser rather than a hot laser.
Thank you. Now, I think the time is over. I'll give the chairman of the session wants to give some comments. Dr. Tariq?
Yes, sir. I have a question from Dr. Amish Akil. So he mentioned that one patient developed endophthalmitis. What type of endophthalmitis patient developed? It was sterile or infective, if it was a sterile endophthalmitis, because Percimab have a higher rate of developing sterile endophthalmitis, even ischemic vasculopathies. The recently published paper, it showed that 22 patients developed endophthalmitis, and two patients among two, they lost their vision. One because of the ischemic type of vascular occlusion, and other is because of the severe endophthalmitis and vascular incidents.
So, are you sure you're talking of brolucizumab, Beerview, or are you talking of faricimab? Because with faricimab, no red flags were seen in the far right study, and you know, uh, immune cases of endophthalmitis usually respond quite well. So what we worry about is significant occlusive vasculitis. That is what we worry about. Now, even in Yosemite and Rhine and Tenaya and Lucerne, there were cases of endophthalmitis. If they're infected, then that can happen to any drug and to any patient. But if they're non-infective, then we want to know whether it's what sort of a, immune response it is. Okay, and where were the cases from? I'm not aware. I'm not aware, because if it was. Okay. Okay. So if it's like one or two cases like that, they will be talked about. We will get like a notification from the industry as well. It's their role. If it was 22 cases, then it would be a national uproar. I'm sure you're talking about brolucizumab, because there were 20 cases of brolucizumab. Okay, I'm not aware of it, but if it is, then yes, I mean, we all have to be vigilant about any new drugs, and if there is, then there will be proper investigation, and we will find out about it.
Thank you very much, sir. Thank you. Indeed, it was a very useful session and excellent presentation from all the participants. Thank you all. One thing I would like to add, Dr. Mariam said that diabetes is our next epidemic. I think it's a huge tsunami which is approaching to our shores, and I think, let me correct Dr. Sidra, Pakistan is now #1 from prevalence point of view. Only 12 years ago, according to IDF, Pakistan was on 7th position. But now Pakistan, from prevalence point of view, it is #1. And about 20 years of age population, 30.8% of Pakistan's population is diabetics. So a lot of advocacy, a very strong advocacy, and untiring efforts are needed to counter this issue, and we have to raise red flags on every aspect. We are all talking about the fancy treatment modalities, but we are not talking about the prevention and the disease at the public health level. So I think it should also be discussed, and there is a need of the day that we should address this issue in front of government authorities, in front of NGOs, and in front of other authorities to support this country and to help us treat these patients on regular intervals and at a proper time. Thank you very much indeed.
Thank you, all of you. The session is closed. Next session, people there will be the next session now. So group photo, please come for the group photo.